咁啊without further delay，咁我不如將時間再搬落去下一個 part 嘅 party 嗰度。咁啊，下一個咧就係QM 嘅團隊同埋香港 U 嘅團隊，咁就分別有 Dr. Christian Fong 啦、Dr. Robin Chan 啦，同埋 Dr. Sherby Pang。Dr. Christian Fong 咧就係嗰個我哋嘅 Clinical Associate Professor of Practice Department of O&T 香港 U， 亦都係 Honorary Consultant Department of O&T QM。佢所講嘅題目咧就係 Different Types of Industrial Grade 3D Printers。When to choose which？ 我諗呢個咧大家都好想知嘅。有好多類型嘅一個 3D printer， 應該點樣買為之最好咧？咁另外一位講者就 Dr. Robin Chan，Consultant Department of Pediatric Cardiology QMH，Honorary Clinical Associate Professor Department of Pediatric and Adolescent Medicine Hong Kong U。咁佢真係會俾一個比較特別啲嘅用途，因為頭先我哋聽咗啦，係啲骨科嘅用角啦。今次咧係同我哋分享嘅就係 3D Printing and Management of Congenital Heart Disease。咁第三位咧就係 Dr. Sherby Pang。Dr. Sherby Pang 咧就係一位 Associate Consultant Division of Plastic and Reconstructive 東華 Hospital， 亦都係 Associate Consultant Division Head of Head and Neck Surgery 東華 Hospital。咁Dr. Pang 就係一位 Plastic Surgeon 啦。咁就會同我哋講嘅咧就係 3D Printing in Plastic Reconstructive and Craniomaxillofacial Surgery 嘅。咁首先我invite咗 Dr. Fong 同我哋做個分享先。Dr. Fong 麻煩你。
係，你好，聽唔聽到？睇唔睇到畫面？
你放大佢啊！好嘅，唔該。
OK， 聽到我講嘢嘛？清楚？
好清楚。
好多謝大會邀請。咁咧就我都係講英文都 OK。如果講書我就慣咗英文。
OK 嘅 ，OK 嘅。
I'll be in English. So thank you for inviting me. So today I'll talk about which type of 3D printers. I think the application use of 3D printing has already been highlighted by my colleagues from PWH and UHK very well. So I would focus less on orthopedics and talk more about the broad spectrum of use of these machines. So in Hong Kong U, we are very lucky. We have had a very good donation support to buy these machines and play. You can say play with 3D printing for the previous 5 years. So we have explored a few different types of these industrial grade machines. The first one is the FDM. This is the same as the one being installed currently in UHK PWH. And we have also the SLS, selective laser sintering printer, just installed last year. So this one is a stereolithography printer we don't have at the moment, and a polyjet. So all of these machines, it's very confusing now. Each of them, they have specific uses and specific strengths. So for example, this is a high temperature machine because these ones use very high temperature to melt the plastic and then to form the parts. So in general, these are good for making tools for sterilization. These are low temperature machines. They generally use light, UV light to cure the plastic products. So they're good for visual models because when you use light, the resolution tends to be very good. So the requirements, what is the best type of 3D printer? It is very hard to define. It really depends on your specific use. So for trauma applications, I'm a trauma surgeon myself. I have to print the fracture models. So it's almost routine now in my daily practice. I need speed. I need the model to be here tomorrow or today afternoon. Then I can do the case tomorrow without delay. Cardiovascular surgeons or cardiologists, they may need the parts to be softer, so a rubbery material. Like Dr. Casey Wang, tumor excision planning, he may want multiple materials, multiple colors, and patient-specific tools. You need the tools to undergo high temperature sterilization, like the steam autoclave we use. That's 132 degrees. Many of the current printers, the products will melt in that kind of temperature. For these tools and implants, you want it to be mechanically durable. It doesn't easily break. So you put a saw there, it doesn't shatter. And the ultimate is the implants. So you want them to be biocompatible, so cause no harm to the patient. So unfortunately, none of the printers can do all of the above at the same time. This is a very busy table, but I just want to highlight each of the 4 printers. They have some pros and cons. So now I'll move on. The first type of machine that we use, this is the commonly known called 3D printer. Layer by layer, there's a heat extrusion. And then this is cheap, reasonably durable, and some of the materials are certified biocompatible, so according to ISO. The problem of these is it still requires processing. As Dr. Casey Wong just said, it's not just something you press a button, it comes out from the oven and you can use it. You have to still do a lot of post-manufacturing processing. Like this, it's mixed with supporting material. That's a humerus fracture model, and we have to remove. So some of the use of FDM are pretty straightforward. So for example, these cases with osteophyte, post-traumatic elbow joint disorders, I can do a simulation in the computer, but it's nothing compared to holding the thing in your hand. So these cheap machines would do this job very well. So I think in every single hospital, having one FDM machine there would help with these cases that require very quick turnover time. So that's a very complex delayed treated elbow fracture. So we're thinking, how can we look at this in the OR? So I think it's common sense now just to do 3D printing. You see the model on table and then do the reduction, do the reconstruction. And then in the same operation, you can see what's the blocking osteophytes or the fracture parts, and then patient get a good range, good function afterwards. This is another similar case. There's a case coming with chronic osteomyelitis, a foot infection. He previously has an open fracture in the foot. So this is infected now. So we're thinking, because the patient previously has a flap there, the blood supply is a little bit strange. So there are connections here and there that we don't want to damage. So what we did is a 3D digital subtraction angiogram to map out the very detailed kind of vascular structure with help from the radiologist. And then we can print this model. But you see, there is some deficiency of the FDM because it only comes with one color. We can guess this is the vessel, but there is no definite saying this is red, unlike the computer screen. So this although helps, some may argue it's not the full blown type of 3D printer you want to use. So other use of the FDM includes the patient-specific guides. So we are commonly doing these nowadays for deformity cases. For example, this very severe spinal deformity, we can do the 3D design in a virtual environment. And you know where your pedicle screws would land. They should not land into the spinal cord, of course. So we can use these jigs to do the procedure. So it only applies to those complex cases. For simple cases, usually the spine surgeons with their free hand, they are also very good in doing this technique. So for this case, model sterilized, brought on table, and this is pre-op, post-op. So it can be quite satisfying to see this kind of cases, very complex, and done within a reasonable amount of time. It speeds up the surgery considerably. So for some of the other cases in Hong Kong U, we have collaboration with teaching departments. Department of Anatomy want us to build this model for teaching. So at that time, we only have one machine, the FDM. It comes in single color. But actually, if you hand paint this model, it still gives you reasonable degree of clarity and resolution. So the student used this model to study the branches of all the arterial supply in the head. So they're currently doing a study and want to make more of these models. So these, again, FDM, it can come with different parts. So very easy to do. I think if every single hospital has these, it opens a lot of possibility for what they can do with complex cases. The problem of FDM, so when you finish the printing, it comes with all these supporting materials and you have to remove it. It's either by manually peeling off, or in this particular model, this is called a water-soluble material. So it can melt in a 70 degrees sodium hydroxide bath. So there is specialized space and specialized equipment needed for all these 3D printing. So Dr. Jones, since you are here, I want to say that if you want to promote this service in HA, specialized space, I think it's very necessary in these. And also for the FDM, the environmental control is very important. So you see, this is a humidity meter we put on the machine, 30% humidity. So what we discover over years is when there's more humidity, it actually affects the printing quality, because the water gas bubbles would form steam bubbles and actually destroy your printing product. So sometimes the part will collapse mid-print and you have to start all over again. And so this is like a total failure of the jobs. They're not so as reliable as you would like. So SLA, this is stereolithography, using a UV source to cure a plastic resin from below the top. I don't have this machine in Hong Kong U, but some hospitals like QE, I think UCH also have this machine. The good thing about this one is the surface finishing is excellent. So, but sometimes these parts are a little bit brittle because it's only low temperature cured, but you can put it in a UV oven and shine it with UV light. It becomes more stronger over time. The resins are still quite expensive for this, but it's very useful for making braces or visual models. Like you need very high clarity, a lot of definition to it. So this one is one of our newer toys, selective laser sintering. So this is called a powder bed fusion technology also. So in a bed of nylon, very fine particulates, powder form. So the machine has a CO2 laser to shine on it and melt these layer by layer. It is like a big baking oven in here. So the temperature has to be very carefully controlled. Otherwise, all the parts will wrap. It will deform over time when the cool down process starts. So it's quite messy because you have a lot of powder in there. But this machine actually, you can run it very cheaply when you have a large amount of products to produce. So like in our unit, so over time we build up quite a large demand of cases, and we can mix different case loads together in a batch of the SLS job and achieve a reasonably cost-effective and rapid turnover of our products. So these are SLS examples, like an acetabulum fracture products. You can see these details, very intricate details. It gives you tactile feedback, collision control, so I can know how I can treat this complex acetabulum fracture well during surgery. And also, moreover, these are high temperature sterilizable. So 132 degrees steam autoclave, no problem. The previous FDM products, you cannot do steam autoclave. So these one we can use to bend our plates, shape around, and easily mark out where you want to put your screws, where you want to reduce your fractures. Very easy, it's very helpful. So nowadays, when I do these acetabulum fractures, I think it's not possible to not do 3D printing because it just simply improves your patient care. So from evidence, there is a lot of evidence already. Reduce X-ray use, reduce butt loss, reduce operative time, and then usually in better function, better reduction. So I partner with a lot of my colleagues here. So for example, Dr. Pang, she does plastic reconstructive surgery, head and neck. So I use this SLS machine to make her these newer types of guides for head and neck reconstruction. She will talk about this, but the guides are very high detail, very high resolution, durable enough to put a saw. So this one is being used already in this case. You see, after sawing, there is minimal melting of the part or destruction by these procedures. Another very high definition print for a facial fracture model. You can see the details. So it gives you much better details compared to the FDM printers. Spinal pedicle screws. So these pedicle screw guides can be made smaller with this SLS technology because it's more durable, and also the print resolution is much better using laser. The problem of the SLS is the selective laser sintering. After it prints, you see it comes out like a batch of powder, and then you have to manually excavate. It's like like the archaeologists excavating the parts from soil, and then it can get quite messy here. Actually, we use a brush and then to remove all the fine particles of nylon dust. And this is also occupational hazard. The user has to wear an N95 mask and also have a fume cabinet for doing this. And afterwards, it's not enough. We still need to do the grit blasting, fine blasting of the parts. So these are like engineering work, real engineering work. So we have a good surface quality of these parts. And then SLS failures are actually quite common because in the middle of the print, some of the nylon material would cure and then create these artifacts. And then the scraper, which scrapes through, would crash. And then you have this problem. And then you have to remove the whole tray and start all over again. Sometimes the parts also would wrap if the temperature control or the material usage is not of enough quality. So these are problems of the SLS. So if the hospital wants to run the SLS machine, first criteria is they have to have a very high product volume. So combining a few hospitals to use together one of these machines may be a good idea. So they don't have to recycle as much material, and also the material, when it's first used, it's always of better quality. So in our service, the prime use examples are complex cases, complex orthopedics, plastic CMF neurosurgery, cardiology, complex interventional radiology, and others like university R&D work and teaching. So these actually comprise of most of our cases. We have quite a large demand of cases built up over years. So you see 218 to 2020, we have 178 cases completed here. And last year we completed 238 cases. I counted by cases and not by the parts. So I foresee after installing more printers, this demand will explosively increase in the coming years. So it's a very good time for HA now to consider systematically launching such a 3D printing surface and think of the cost effectiveness involved. So we have, this is the case mix typically. I'm an orthopedic surgeon myself, so it could be biased because I actually make my colleagues use this a lot. So roughly 2/3 of our case are orthopedics. 1/3 of our case are shared between cardiovascular, head and neck soft tissues, and also other medical devices manufacturing. Over the years, we have almost 600 cases done. So it's quite a busy job, and I have to hire a full-time engineer to do this kind of work. So this is one of our other printer, the polyjetting machine. So it is same as your home inkjet printer, only that it does it in 3D. So your inkjet machine at home will print in multiple colors. There are multiple inks. You can also use multiple materials, like a softer material. So this is an example printing a hand, a human hand with layers that would mimic the actual soft tissue status. So, but this is also not durable because it's light cured. It's a UV light that shines on the model every time the print head pass through and lays down these resins, and it's still quite expensive. So for example, these HCC tumor models, we can make for the HPP surgeon friends, you can see a very good definition. There's the tumor. That's the hepatic vein. That's the portal vein. You should not cut into it. I'm not the surgeon myself, so I cannot talk into great depths of these models, but I think it should be helpful in them resecting the tumor. These are the very complex cases, like a congenital craniofacial deformity. So I was requested to help with this by a private surgeon. So he wants to see the very detail, where are the branches of the carotid artery going to the graft. The patient has a previous free graft to the mandible and it's fused, and he wants to resect it and not cut off these blood supplies. So I can see it in details. The material is made of translucent material in the skull, and the implants, you can use a reference. I use a different color. Cardiologists would love this kind of printers because they can do soft parts like this rubbery print for a aortic stenosis case. So to plan how to put a TAVI percutaneous heart valve in it. Again, I'm no cardiologist, so that's the amount of detail I can go into. I work with pediatric cardiologist, Dr. Robin Chen, quite closely. So these are some of his fantastic models of a very complex heart of the baby. So I combine using two printers, One is the FDM, the other one is the polyjet to make. There's a rib cage where you can plan where to transcutaneously do your procedure. And you also know the anatomy inside. You can flip open the heart and then look at the chambers. So here, these are other examples, like this is a renal RCC, renal cell tumor, with an aneurysm just next to it. So the surgeon wants to see where the aneurysm is related and plan the resection. So getting to this in the the polyjet printer is actually not easy. We went through a lot of trial and errors, and then we think that it will do its good job in the first time. But you see, actually, when it's printed out, it's not so glossy, and the finishing is not that good. We have to go to all these modeling shops and then get these sandpaper, modeling clear lacquer spray, and then eventually you get a good quality model. And because the cost is very expensive, printing a whole liver actually costs Hong Kong dollars, $10,000. The machine wastes a lot of material. Most of the material is just sprayed into the head washing basket. And sometimes the color, the hardness is unpredictable. So you have to start with a small model first before printing your full size print. So sometimes unpredictable. Good thing the software lets you predict how much time and how much material is needed. For example, this liver model, 3 kilograms of material and 1 kilogram of support. That's exactly the cost, over 10,000 Hong Kong dollars. So you see in summary here, we have talked about the different polymer printers, plastic printers. So for sterilization, the FDM and the SLS is okay for making the surgical guides and tools. And then for multicolor prints, it is mainly the polyjet and translucent models. Sometimes the SLA can also do it. So for rapid turnover, I think you need a good caseload if you want the SLS, but usually the FDM is the best for rapid turnover. For the resolution, so best detail, the light-based SLA or the polyjet, these are good. So handling is easiest in the FDM and difficult for the SLS, but average for the other two types of machines. So there are various uses. So I think to have a full-blown 3D printing lab, you have to have all of these type of machines. So one type of machine we don't dare to have in the hospital is the metal printing laser sintering. So I think this is courtesy of Mr. Edmund Yao, his company's printer, doing a laser sintering of a cobalt chrome implant. So I think it's a Taylor implant made for a previous case in PYNEH, very famous case by Dr. Diu, a patient with a talus being lost in a traffic accident. So for us, we also use Dr. Edmund Yao's service to have these metal jigs for either reduction of a fracture or cutting for an osteotomy. So we tried this multiple times. It's much better than the plastic because it's very durable. You can have this high-speed saw, run it around, and then the metal guides will never break. Unlike the FDM guides, it actually has a little bit of debris created when it's printed by FDM. So plastic is not for everything. Like some of the cases you need metal, especially lower limb type of osteotomy where you have very strong hard bone. I think the metal cutting jigs would help. So this declaration, conflict of interest, I have no financial conflicts with Mr. Yao's company here. So here, 3D printed talus, I think this is one of his company example using the patient with a talar defect. Dr. Diu and Mr. Jonathan Wen from PLI. I think they are one of the pioneers in 3D printing too. And then in Thailand, actually, there's another case that we invited to go there to do similar stuff. So with the metal printing, I think Dr. Casey Wong already talked about this because it does this very good microstructures for bone ingrowth. So in China, many surgeons are already doing this. Implants customized, highly customized using this porous metal. But of course, we do have a little bit of little bit of regulatory hurdles to overcome. This is one of our example cases, the proximal humerus osteosarcoma. So there is not enough time for him to wait for a conventional, mega prosthesis. So we asked Mr. Yao's company to do this. I actually did part of the designing myself, so it's really fun to do, I would say. But we also were very meticulous in planning all the FDM work and making sure the mechanical strength properties would be okay. So end up the patient has quite a reasonable function with this fused scapulohumeral kind of implant, which I think is the first type of such implant. So our case called per cost, I just want to give you an idea. Utilities like power and maintenance is very little compared to other things. The material can be quite little, the cost. The software actually costs a lot. The 3D printer, if you're doing industrial grade, costs more, and the manpower costs the most. The manpower for segmenting the models, for actually treating the, dealing with the imaging and also doing the back and forth trial and error, that's a lot of manpower cost. So I think a specialized center doing all of this is cost effective. So there are studies out there showing that in complex case, when you do it enough, because it saves some surgery time. So assuming a 2,000 Hong Kong dollars around per cases, there is a strike even cost when your center can do around 60 cases of complex 3D printing per year. So you gain back the time used by saving the OR times. So in our center, we also pay a lot of attention in cutting costs. Like a pelvic fracture model, we would not print the whole pelvis. The whole pelvis costs you 21 hours to print. Comparatively, if you just print the relative acetabulum, it's only 5 hours, and the material save is a lot. You have a lot of environmental impact if you print the whole bone every time. It's plastic, you don't want that. So summary, we have 4 prime technologies: the FDM, fused deposition modeling, heat extrusion, sterile lithography, SLA, polyjetting, and powder bed fusion, also called SLS, selective laser sintering. This more specialized, more difficult to control when you get down the complexity. No single printer fits all, and I think a very highly specialized high volume facility and manpower is recommended if for HA they want to do the higher grade kind of polyjetting and SLS. Doing this in university or high volume centers would be, I think, recommended. So I acknowledge all my friends, all my collaborators. I collaborated with almost all of the HA hospitals to do some printing jobs every now and then. And then next Saturday, the Hong Kong MA, I want to just say, also have this another forum. There's no overlap with the speakers and the topic. So for those interested, just go to the Hong Kong MA website. You can register. Thank you.
Thank you, Dr. Fang。before 我哋去 move on 係下一個講者 One Open Chain 之前咧，咁我就有少少澄清嘅，唔係澄清，即係咧，大家應該聽到咧，經常都話同阿 admin 好多溝通啊嗰啲咁，嗰個 admin 咧係 Mr. Edmund Yao， 唔係我啊。OK， 咁不如我哋 move on 去咗聽咗阿 Dr. CHEN 講關於嗰個 3D printing in congenital heart disease 之後，我哋一次過先做一個 Q&A。將時間交俾 Dr. Open Chain 好冇？
Morning. So a bit of clarification now. My unit, the pediatric cardiology unit, has already translocated to the Hong Kong Children's Hospital, but still I'm still part of the Hong Kong West Queen Mary family because I'm the honorary consultant of the Department of Medicine for the Adult Congenital Heart Program. I'd like to thank Chris especially for inviting me and also for supporting the project of 3D printing in management of congenital heart diseases. So let me see. So a bit of background. So we'll cover a bit of the making of a 3D cardiac model, which has been covered by Chris mostly. The types of 3D cardiac model, not really particularly concentrated on the material, but the format of display. And then I'll go through the utility of 3D model in congenital heart disease, which essentially is for surgical or interventional planning, simulation, and some advanced utility And more importantly, it's for education of staff and counseling. So it's really a change of gear from the utility in orthopedics or in oral maxillofacial surgery, which is very advanced with lots of implants. But in cardiovascular, it's really more of a starting phase. So the 3D cardiac models in making, just very brief, there are a lot of steps, especially if we're talking about starting such a program in the HA environment. It involves a lot of resources, not really talking about the printing itself, but all the jobs that's required before that. So we have to have a good quality image 3D data set, and with the idea of making a model in mind when you actually scan the patient. Because most of the time, especially in complex congenital heart conditions, we are focusing on a particular part of the heart to image it. So the rest of the heart or the blood vessels or nearby structures are really not in focus. So it's really difficult to make a good model if the image quality is suboptimal in that sense. And the other very labor-intensive part would be segmentation of the anatomy. I'm very lucky to have support from Chris and his team because I myself is too busy from clinical work to actually spend a lot of time in segmentation. But we would like to have a local team who are interested in segmentation to do the work so that we can actually buy Chris' team some time to create more primary files for printing. And obviously there are additional designs where how we want to cut the model, how we want to include different transparency of the model, and then the creation of the STL file, and then finally it's the printing part, which Chris has already covered very nicely. So that in terms of the types of the cardiac model, there are essentially two big types, one of which is the blood pool model. Essentially, when you consider imaging like CT and MRI, those would be the contrast enhanced bit. So it is essentially where the blood is. So we usually segment those from the CT and MRI, and they can incorporate non-cardiac structure very easily. And the advantage of which is it's as excellent for extracardiac vessels as well, and good relationship with the nearby structures in terms of airway and esophagus, which is very important, especially for cardiovascular surgery. But the disadvantage of these type of models, it doesn't show up the intracardiac structure very well. For example, in congenital heart, there will be lots of intracardiac defects, for example, in septal defects. So for intracardiac problems, we'll probably use hollow models, which essentially is building a mesh around the blood pool. So you can see from the imaging from on the right, on the top is the source image, and at bottom it would be the model that was created from the source image. So it actually represents the myocardium and the vessel where you digitally remove the blood pool. So there are also subtypes with this kind of models, including models with cut plane, so it's easy to demonstrate intracardiac lesions. And there will also be intact models. I'm going to show you some examples later on. So these intact hollow models, which means that we print the whole thing without actually cutting it, it's actually a better representation of lesion in real life. And you can also couple it with very special printing material so that the model is actually malleable, foldable, and even surgeons can practice on it by cutting it and doing dummy surgeries. So it's very ideal for surgical or interventional simulations. So as mentioned, the role of 3D model or 3D printing in congenital heart disease, the main bulk of which, or the main literature of which, would be on surgical planning for complex surgery. And nowadays, there are lots of surgical simulation programs around the world which uses 3D printing as a base rather than cadaveric or virtual surgery, because they actually gives you the tactile response. And from interventional cardiology point of view, which, well, I myself is a pediatric interventional cardiologist, the literature and the usage is less as compared to surgical, and it's more so for planning and feasibility testing, especially for some novel procedures. But it's actually getting more and more popular around the world as well. So in terms of the category, we have congenital heart with complex intracardiac anatomy, extracardiac or vascular reconstructions, in heart transplant or ventricular assist device planning, and also in very specific conditions like airway diseases. And for myself, it would be complex non-invasive interventions. So let's go through them quickly one by one. Surgical planning has been really the cornerstone of 3D modeling in congenital heart disease. It has been used for over a decade. And the rationale behind is for complex anatomy, even if you have pristine imaging, it's not very easy for the whole team to understand the anatomy. There will be surgeons, there will be cardiologists, there will be trainees, there will be nurses in the team. So it's actually a lot easier if you can hold on to a 3D model and we point specifically at, say, where we actually want to close the ventricular septal defect. For example, in the picture in the model that was shown on the right, this is a complex double outlet right ventricle. Probably it's an alien language to most of the audience. But the surgeons and the cardiologists will have to decide where actually we should put the patch to channel the left ventricular blood to the aorta in this complex anatomy. And with this sort of cut model, we can cut in different planes and we can point exactly where we want to put the patch and what the potential problem would be. And in some specific cases, we can actually do a dummy patch and print that as well, and print various different kinds of dummy patch to simulate the end results. So it aids the team in terms of better communication amongst the team, and it also anticipates the outcome, as I've mentioned. So as mentioned, other than intracardiac things, in congenital heart population, there are actually lots and lots of extracardiac and vascular problems that needs to be settled. For example, this is a case with major aortopulmonary collaterals. Essentially, part of the pulmonary vasculature is very abnormal and supplied by systemic collaterals, which is from the aorta itself. When you look at this particular diagram, the orange part is the aorta and all its branches. These are abnormal branches that supply the lungs. So in the effort of surgical correction, you have to so-called unifocalize them. Unifocalization means you connect all these abnormal blood vessels back to the pulmonary arteries. So in the traditional imaging world, we use catheterization, CT, MRI. Well, those are really 2D, or even if you have 3D reconstruction, still it's not exactly the same as having tactile experience with a model. So the surgeons can actually look at the spatial relationship of these structures to nearby structures and how they can actually do the surgery reconstructing them. And at the lower panel of this picture, this is actually the same view looking at the anatomy and also at the surgical perspective. So it actually helps with precise demonstration of all the structures, and potentially quite similar to orthopedic surgery with shorten OT duration. Surgical planning for ventricular assist device or heart transplant is a new perspective in terms of 3D printing. So in this example, well, probably if you think about it, for the conventional VADs or heart transplant, the 3D printing is probably of less importance because the anatomy will be more or less the same. But say in patients of adult congenital heart patients, with failing ventricles, their blood vessels, their ventricles can be all over the place. It can be very abnormal. The approach of surgery would be very unusual for the surgeons. So there are a couple of complex anatomy that I'm not going to go through because, again, there will be alien language to most of the audience. But it does help the surgeons and the assistants and the cardiologists to actually understand where's the best place, for example, to put a VAD. For example, in this particular example that I've quoted from a paper, this patient has a complex systemic right ventricle. And as compared with the left ventricle, which is smooth wall, and right ventricle is actually very trabeculated, very muscular. And if you open up the ventricle like this, you actually see lots and lots of muscles. So it's actually very useful for the surgeons to plan, say, putting in the VAD, which is essentially a metallic pump, right there at that position. They can anticipate problems, say the pump head would be engaging right against this muscle, and they will have to think of ways to work around that. So in terms of printing with cardiac catheter interventions, as mentioned, it's growing in popularity, but it's not as developed as compared with that for surgical guidance. The potential benefit is that there are a couple of folds in terms of potential benefits. First of all, road mapping, just like conventional imaging, but it actually gives you a much better idea of how the structure will look like with relationship to the rest of the intrathoracic structures. It helps to be a roadmap, reduce procedural and importantly, fluoroscopy time. And in many of the novel procedure, it actually helps for feasibility testing. Thanks for Chris' team's effort. We did have a couple of models that we actually tested a few novel procedures that I'm going to show you one of those. And we also can decide on approach and ballot plannings for, say, for example, in the various interventions, we can try different kinds of wire position with the model itself, rather than trying it on the patient, which we used to do. So we're just going to go through the procedures as examples with stenting, percutaneous valve implantation, and hybrid procedures. So these are some examples we have. These are actually quite easy to understand because these are vascular interventions. We do a lot of bench testing with 3D printings. Obviously, the limitation in hospital authority as such is that, okay, so we have the support of 3D printing, but all these implantable devices here cost money. So it's actually not that easy to have this sort of implants for us to do dummy implantation. So we usually use some expired implants, or if otherwise that we have collected some implantation otherwise. So these are some of the examples. For example, in aortic position, we put aortic stents, and in right ventral outflow tracts, as mentioned, we can try different wire position. We can wire the guide wires to the right pulmonary artery or the left pulmonary artery and see the effect of which before we actually decide on a plan of intervention. So this is one of the case I'd like to show you. Let me just cut the background noise. So this is actually a hybrid intervention, implanting a valve into the pulmonary position. So it's one of the first in Asia, and despite we have a lot of communication with expert team in Europe and in US, it's difficult for the whole team to understand how it actually works and how the sheath would behave in the heart. So we actually printed a model, the soft part of the heart cardiac model, and also the rib cage, so that surgeons would have an idea where exactly we can approach. So we finally decided on a subcipher incision, put in a sheath, and as mentioned, we considered guide wire position to the left or to the right, which in this case, left-sided intubation was better. And we also decided whether we need extra sheath or extra support. And from this video, it's actually the procedure itself. And it actually went very smoothly and exactly as we have predicted with the model itself. And this is the final outcome. So we're actually very happy with this particular case, and the model did actually help to shorten the procedure time, as we don't really have to try a lot of things with the procedure. So this is another novel procedure that we did in a complex congenital heart patient, implanting an investigational device in a patient. So again, we printed the model, we discussed in the team. So there's actually, this is the atrial septum, and the point of the procedure is to decompress one of the atrium. There has already been a stent in situ, which is pointed by the yellow pointer, and we want to implant a new device. So we have to understand where's the best position to implant this device, and whether there will be potential of interaction with nearby structure. So the model actually helps the team to understand where we should puncture, the echo specialist to actually guide us where exactly we should land the thing, etc., etc. So again, this helps in shortening the procedure time and improve precision. Finally, some interesting development in catheter intervention. So the 3D printing in terms of congenital heart, there are potential pitfalls. The quest for the perfect material, as mentioned by Chris, so it has to be patient-specific, degree of soft tissue recoil and stiffness. We are trying to print out models that imitate the natural environment, but it's not always that easy, because in some patients there will be calcification as well. So how we choose between different material or mix and matches of different material is really an art, more than science sometimes. And the effect of blood flow, so it's despite printing the model itself, especially in interventional cardiology, there's also another effect from the blood flow. So from this interesting work from Mariginis, they actually not only printed the model, they actually put it in a flow simulator to actually simulate what the flow does to the cardiac structure and how intervention would affect the structure. This would definitely be a very interesting development. However, this is extremely labor and technical intensive. So just to just some icing on the cake, some advanced application would include customized devices, and this is not really very popular as yet in terms of congenital heart, but it's actually gaining favor in complex airway management to have customized 3D printing bioreabsorbable material, and these are external airway splinting or airway support, to be exact, for patients with critical tracheobronchial Malaysia. And other advanced applications, as speakers have mentioned, is bioprinting. So it's really still at experimental stage. So actually printing bio ink deposit in specific locations to reconstruct complex structures. So for example, vasculatures, even valves. And this would be a very interesting development, because we are still in the quest of finding the best material for a long-standing implantable valves. So just a few more slides on other utility of 3D printing. It is a very important area to educate staff, and it's always very difficult because in congenital heart there are complex anatomy, and it's not always easily understand when you just look at textbooks and stuff. So 3D printing actually helps medical staff to understand complex and rare anatomy in terms of ad hoc teaching. And in the contemporary state, it's also a curriculum-based teaching using these complex models. And obviously we have case-specific teaching and education to better understand the complex anatomy. And the newest development is a hands-on training with surgical and intervention simulation. This is courtesy from a good friend from Toronto. So 3D printed models are actually used widely used nowadays for surgical simulation. It's really curriculum based, rather than in the old days, it would be very ad hoc. When you have a case, you go to learn it with your master surgeon. Nowadays, you can actually learn how to do complex surgeries on these models. And in terms of counseling, the patient and parents counseling is, again, a very important aspect in complex congenital problems. So this is a model that we actually produce to help counseling of the parents, explaining to them how we actually do the intervention, and actually, again, ended up exactly the same as we have planned. So as a concluding slide, so the major utility in 3D printing in congenital heart disease is mainly for surgical and interventional planning, simulation, and we also have a lot of enthusiasm in developing advanced printing. Staff and patient parents education and counseling is important. Locally, in terms of the hurdles for future development, is really for manpower, resources, flexibility, and networking. I think for us, the difficult part would be we are engaging in very complex structures, and we are serving a small bunch of very, very complex patients. And it's difficult to train personnel by bioengineers or even medical staff to do the segmentation. So this would be one of the major hurdles. From my experience when I work in London, there are actually a team of more than 10 bioengineers working in the congenital heart department to do segmentations, prototyping, et cetera, et cetera. So this is a huge gap that we need to consider how we can fill. Obviously, the downstreaming of the printing, how we should centralize or decentralize the printing is another important topic to discuss. So thank you very much. And again, I would like to acknowledge Chris and his team's help in this very meaningful project. Thank you.
Thank you, Dr. Chan。都聽到好多位講者咧 repeatedly 都講咧，其實 3D printing 對手術其中一個好重要嘅嘢就係 shorten 嗰個 OT time 啦咁啊，我坐度聽，我不期然諗起我一位都幾尊敬嘅一個神經外科醫生，洪君毅醫生。咁啊，其中一個佢講嘅説話就係病人早1分鐘離開手術室咧，就早1分鐘康復。咁我哋move on 去聽阿 Dr. Sherby Pang 同我哋分享下，到底 3D printing 喺 reconstructive 嗰方面又可以有啲咩嘅發展？麻煩Dr. Pang。
Hello, can you hear me? Can you hear me?
Yes, we can hear you. Yeah, we can hear you. Yeah.
Okay. And can you see my slideshow view, or you are viewing the presenter view?
睇到你個 slide 啦 ，OK 嘅 ，I can see your slide.
Okay. So first of all, I would like to thank you, Edmund, for the kind introduction in the beginning. And also, I would like to thank Dr. Fang for the invitation to speak in this event and to share with you some of my experiences in 3D printing. As mentioned, I'm a plastic surgeon working in the hospital authority, and reconstructive surgery composed the main part of my work. The aim of reconstruction is to restore bodily functions and to reconstruct the missing body parts. All reconstructive surgeries are actually personalized since no defects are the same, and each individual has his own expectations. So 3D printing allowed us to provide tailor-made solutions for all of our patients. With the advances in medical imaging and also 3D printing technology, there has been a surge in the concept of personalized surgery in the medical field, especially in plastic and reconstructive surgeries. This provides us with increased precision of operation, decreased operative time, as mentioned by Edmund, improved surgical outcome, and better patient satisfaction. In the following 15 minutes or so, I would like to share with you how three-dimensional printing provides solution to clinical problems in reconstructive surgeries in the head and neck region, including bony reconstruction and mandibular reconstruction, facial fracture management, and also some soft tissue reconstructions. These are patients who suffered from bone tumors of the mandible. On the right side, this is an ameloblastoma of the mandible, a benign tumor. And on the left side, it is a squamous cell carcinoma of the oral cavity, which has invaded the jawbone. So in both of the cases, the mandible, part of the mandible has to be resected. Mandibular reconstruction after mandibulectomy with free fibular flap with the aid of virtual surgical planning and 3D printing has gained its popularity among reconstructive surgeons over the past decade. It has shown in various studies that with virtual surgical planning and cutting guides, it decreased operative time with increased precision. And it's particularly important as the aim of mandible reconstruction is not only to restore the bony continuity, but also we have to match the maxilla and the mandible so that we can provide dental rehabilitation in the form of dental implants. It is also important to restore the facial form of the patient. Thus, precision is very important for a successful mandible reconstruction. This video showed preoperative virtual planning of mandible resection and free fibular flap reconstruction. We have been using this approach since 2017 with the help of Dr. Fan in designing and also creating the jigs. So you can see that's the resection guide of the mandible. And for the recent advances, as mentioned with the new addition of the SLS printer, the printing material is not only limited to thermoplastics, but also we have a more higher resolution printer which can print nylon material. And then the strength is also increased with better precision. There is also advances in the design of some of the cutting guides. This is a commercially available cutting guides. There it's a metal box which reinforces the sewing box so that when we are sewing with a high speed saw, the plastic won't be damaged. And also patient-specific implants is also available now. So it's particularly helpful in more complex reconstruction, for example, in this configuration, and it can also act as a reduction guide for the occlusion. This is how the resection guide is fixed to the mandible, and this is the sewing boxes. Similar cutting guide can be designed and fixed to the fibular bone. This is a free osteocutaneous fibular flap with the skin island, fibular bone, and the vascular pedicle. After osteotomy of the bones, then for our practice, we will fix the fibular flap to the native mandible with mini plates. And in this case, it's in a double barrel configuration. This is the immediate post-op x-ray. You can see with the help of the jigs and the cutting guides, the occlusion, symmetry, and the facial form can be maintained after the operation. And this also provides a platform for future dental rehabilitation. The occlusion is maintained after the operation. So apart from the mandibular reconstruction, 3D printing can also be applied in the management of facial fractures. 3D images allow surgeons to visualize the fracture three-dimensionally and also at real time. It is very helpful in complex fractures, such as in this patient who suffered from bilateral Lafort fractures and also mandible fracture. Apart from visualizing the fractures, the models can also allow us to plan our incisions and also approach to fix the fracture. It is also very important, as mentioned by Dr. Chen, in patient communication, because with the model, then the patient knows about their fracture and how we're going to fix it. Blowout fracture of the orbit is one of the commonest facial fracture, and we can encounter in our daily practice. With the orbital floor defect printed out as shown here, a MedPort implant or a titanium mesh can be tailor-made to fit the defect and inserted subperiosteally to reconstruct the orbital floor defect. A MedPort implant comes in a rectangular shape, so we always have to tailor-made it to fit the orbital defect. This is another patient with a facial fracture. It's a comminuted fracture of the frontal zygomatic suture, and with the bony fragment impinging onto the eyeball as shown here on the CT scan, and also from the indirect ophthalmoscopy. This video showed the reconstructed 3D image of the fracture, and the model was subsequently printed out. During the operation, care has to be taken to retrieve this impacted bony fragment from the very small incision without damaging the eyeball. So you can see how the actual bony fragment is retrieved. The pre and post-op CT of the same patient after 6 months post-op. Apart from bony structure, three-dimensional printing can also help in soft tissue reconstructions. This is a boy suffering from a condition known as microtia, which is a congenital condition in which one side of the ear is either very small or even absent. In our approach, we usually will do the Nagata two-stage reconstruction with the patient's own rib cartilage. In order to avoid radiation of the CT scan in this age group, the normal ear, which is a contralateral ear, will be scanned with a 3D scanner, and a flipped image will be produced in the computer. And the contralateral ear that we hope to craft can be printed out to act as a guide when we're actually crafting the framework of the ear out of the patient's own rib cartilage. Then the framework will be reinserted into the skin pocket for reconstruction of the ear. So this is the same patient 2 years after the operation. And please note that his other normal ear, which is actually a bit prominent, is also corrected for better symmetry. This is another patient suffered from a congenital condition. It's a girl with congenital left macrostomia and also hemifacial macrosomia, which means that her whole left face is actually smaller. And also her mandible is hypoplastic, as you can see here. So when she was small, the macrostomia was repaired and there was a costochondral graft performed when she was small. Now the patient is 20 years old and she wished to have some improvement for her facial profile because her chin was very receding, and we planned for a genioplasty for her. So you can see that, again, with the computer software, we can plan the osteotomy for genioplasty pre-op. And on top of that, the soft tissue result can actually be simulated by the computer software. So we can view the result of how our osteotomy can help the facial profile of the patient. As the mandible is very hypoplastic, we have to avoid overstripping of the periosteum, and the osteotomy has to be precise. Thus, a personalized cutting guide, as shown here, is particularly helpful for this patient. This is our patient 9 months after the operation. As you can see, the receding chin is much improved after the genioplasty, and the facial profile is also improved. Apart from bony reconstruction, we also see patients who require soft tissue reconstruction of the face because they have facial asymmetries. Again, these two younger patients actually suffered from a condition which is the same as the previous lady, known as hemifacial macrosomia. Half of the face is actually much smaller compared to the contralateral side. And this is another patient suffering from another condition, which is acquired, known as a Perry-Romberg syndrome, in which the half the face is affected, but it's not congenital, it's acquired. So very often, at a certain point of the treatment for these patients, we will offer to fill up the defect with the patient's own fat to obtain symmetry between both faces. The procedure is known as autologous fat transfer. So for autologous fat transfer, is actually divided into 3 parts mainly. First part is liposuction to harvest fat from either the thigh region or the lower abdomen. Then the fat will be processed and centrifuged, and we will collect the fat lobules, and the fat lobules will then re-injected into the patient's body, the recipient site. And recipient site can actually be anywhere in the patient's body as long as we wish to augment the volume in that area. So for example, in this patient who comes to us with facial asymmetry and complained of a depressed left cheek, we have offered autologous fat transfer to this patient. And with the help of the 3D scanner, we obtained these point cloud images that you can see here. And then with computer software, the normal face, the right side, was mirrored to represent the final outcome. And then we can subtract the mirrored image and the original left face. Then we know exactly how much volume we actually need to augment. And with the software, we can also look in a three-dimensional manner that where is the part that we actually want to inject fat for volume augmentation. So this is the last slide. Thank you for having me today to share with you some of my experience in the head and neck region reconstructions in form of three-dimensional printing. And I hope three-dimensional printing will be the answer of lots of our reconstructive operations, because as mentioned, all defects are different. And for us, personalized surgery is very important. And I believe that three-dimensional printing or three-dimensional bioprinting will be the answer of the above problems. Thank you.
唔該晒多 Pan， 咁啊多謝3位講者多方啦、多 CHEN 啦，同埋多 Pan， 特別係多 Pan 啦，多 Pan 而家係放緊假嘅，咁我頭先都聽到一啲好美妙嘅聲音喺你背後嚇。OK， 非常之好。好啦，我哋喺度咧又到停一停，咁就清一清啲問題，同埋我有引發啲討論嚇。咁首先嘅問題，我諗問阿 Alfred 啦，作為 engineer， 條題目就係簡單講就係有冇同 ONG 產科合作過關於 3D printing 嘅咧 so far？ Alfred
有嘅，有一個 case 係做嗰個 ultrasound 嘅 segmentation 嘅，咁但係我哋得一個啫，目前合作嘅 case 就，咁就嗰個 image 我記得都幾唔清楚嘅，但係到最尾就都叫做即係整咗個 B 啦，就如 ultrasound 咁樣。
OK。好，咁希望可以答到個問題啦。咁另外咧，都想大家有少少討論嘅。咁頭先有講者都提過㗎啦，關於一啲 centralized printing 啊，或者 decentralized printing 啊嗰啲咁。或者我諗邀請下唔同嘅地方都同我哋分享下呢個睇法啦。PW 啊、QM 啊，或者嚟緊講嘅 QE 啊都可以啊咁。咁另外都想大家都順便提一提就係，咦，其實我哋真係唔係好知啦，你哋就最熟啦，就係而家個 3D printers 嗰個發展會係點樣咧？即係佢會唔會好似Tesla 咁轉頭就出個新 model 出嚟啦，又唔同咗啦？咁咪我哋咪投資咪好大咯，買部機都唔平噶嘛。咁都想睇下大家對於呢句嘢有咩睇法，或者逐個講啦。我哋揾PW 開始先啦。多喎係咪到？或者多咯？
我自己個人覺得咧 ，3D printing 就 in long run 一定會 integrate 喺我哋個 clinical practice 裏邊嘅。咁我就頭先都講過啦，我又覺得咧，X-ray 佢自己一定有 in-house 嘅 service 嘅，即係咁。但係我哋要 limit 咗即係要睇清嗰個 scope 同埋個 delineation 究竟自己編到啲乜嘢，有啲咩要出邊編咯。因為我係相信我睇個 panel list 裏邊Christian Fan Stephen 亦都答咗咧，其實佢都覺得咧10年以嚟嘅 model 都唔會有好大改變嘅嗰啲 printer。不過咧呢個我諗就我哋要定，但係咧譬如有啲 metal printing 咁其實今朝大家都睇到啦 ，metal printing 我哋一定係會喺出邊 outsource 咁做啦。咁呢兩條線點樣走咧？點樣 integrate 咧？反而先至喺個 surface model 要諗清楚咯。
QM 多方或者多 CHEN 有冇咩同我哋分享？
係嗰啲 printer 其實係佢通常個 life cycle 都比較耐嘅，因為喐下都100幾200萬一部啦，佢起碼用10年嘅。反而佢係啲 material 成日會更新啦，同埋就唔似我哋啲 consumer products 咁樣 iPhone 每年換一換，反而佢係容易 upgrade、容易整、容易 support 嘅，因為佢係想我哋真係用得好。咁所以我覺得投資多啲去買一部靚啲嘅機咧，即係都可以用相當耐嘅。就我初都好擔心會唔會買1-2年就冇用啦。咁但係你見 PW 部機，佢由05年裝，佢用到而家都係仲係好好嘅。我哋都係跟佢咁樣買咧，就即係冇買錯，我覺得完全。
其實我哋部機咧13年買，用咗7年，暫時咧即係供應係偏骨比較好嘅機啦。咁我哋的確就睇下先，咁我哋的確 我 video 好似有啲問題啊，唔好意思。
我睇到你，冇問題。
一開佢棘住。咁咧，其實我哋部機都幾襟嘅，所以我哋 so far 都真係冇乜大事壞過。但係其實留意到最近3D printer 一個趨勢咧，其實就有一款機咧可以print比起我哋而家用緊嗰部咧係快100倍嘅。咁咧係美國出㗎啦。咁最近亦都大陸咧有一間廠咧就其實係嚟自清華嘅一班人，咁佢都成功即係做到一部類似嘅機。咁佢就係快啲，但係你話嗰部機襟唔襟咧，就其實好成熟嘅 3D printer 依家，其實你要佢爛唔係太容易嘅事嚟咯，所以就係一個咁嘅情況。
我諗當然 printer 係一定喺 corporate 嘅 level 會諗嘅嘢啦。咁頭先阿 Chris 或者其他講者都有講過，即係其實都好襟用。咁但係我諗另外一樣嘢要 consider 係 expertise。其實譬如即係頭先有講 in-house 或者係 non-in-house 嘅嘢，咁有啲係 fast turnover，當然係 in-house。譬如阿 Chris 話佢啲 trauma 嘅 printing 咁要好快。咁 as compared 譬如我嘅 subspecialty， 我係啲好 complex 嘅，可能佢需要花喺 segmentation 嘅時間咧會多過 printing itself。咁變咗呢啲就可能係要啲 specialized source 啦，有經驗啦，或者甚至係啲 complex material 要 outsource。咁第三個facet 咧就係到一啲比較 investigational 啲，譬如真係好似話 print 一啲 devices 一啲可能 novel device implants 一啲。咁變咗我諗最緊要係個方向，我哋諗到我哋有幾多嘢，我哋做到幾遠啦，有幾多嘢係真係 research base 去做啦。咁同埋喺人手嗰方面，其實我諗反而呢一個對於我嚟講啦，係最大嘅樽頸嚟，因為我係個 clinician， 我本身 clinical work 已經係 overload 咗好多。咁全靠係因為 Chris 個團隊咁幫手去幫我做好多 segmentation 嘅嘢。如果唔係，即係淨係靠我咧，或者我要去揾一啲有興趣做嘅人咧，其實都係攞緊大家嘅 extra time 去做。咁我諗呢一方面係真係要認真去考慮點樣去發展。
Echo at Robin 咧 segmentation 嗰度係好需要專人去做，而且嗰個人可能係可以做好多科嘅同一時間，即係佢未必一定係淨咗一科。所以 radiologist 我諗或者 radiographer 甚至或者有興趣嘅 engineer 呢啲都係可以培養嘅。
我知有時間問題啦，一陣 QE 仲要 present 啦，但係我想好快問一個問題咧，大家就係我見到有唔同嘅 material 啦 ，resin 啊、plastic 啊，即係都係 plastic 嗰類啦，或者 metal 啦。其實而家我哋有冇啲 dream material 咧係暫時未有啊？即係我聽到 bioprinting 啊嚇，咁如果喺你哋心目中咧，其實係未有啲或者單 part by 啊，或者係大家好缺，即係心目中係有啲 material 咧，如果有咧，就會 3D printing 嗰個進步會更加大。有冇啲咁嘅idea 喺度 ？Chris 有冇？
有啊。嗱，潤芯咧就係最貴嘅，又軟又透明又平，你又可以控制到顏色嘅咧。呢個係缺嘅，其實而家得一間廠做到類似咁，但係其實都仲好多drawbacks， 即係佢好貴啦，同埋佢個顏色 mix 嘅時候咧好 unpredictable。當你要多啲顏色咧，佢就一定要硬啲嘅，咁又唔可以又軟又透明，所以即係呢啲 combination 係我諗嚟緊幾年會發展嘅。
好，
我 KC Wong 啊，我想 share 咧，其實 just brainstorming 嘅啫，時時都講話 in-house outsource。其實 HA 會唔會有個情況咧，就係話將 commercial 嘅 partner 咧，就喺醫院嗰度做，即係好似大家樂喺搞餐廳 circle provide 個 service。咁其實又係 in-house 係 outsource 啊。咁變咗你好多 running cost 啊，啲折牛嘅 cost 就唔使 HA 去負擔嗰個風險咯。咁 咁你 industry 你入嚟，你去見到有肉食佢先會嚟入嚟嘅啫。咁其實我覺得其實喺外國其實係咁做嘅。咁變咗呢一個都可以係其中一個方向可以討論咯。
我見到阿邱生即刻岌頭啦喺啲現場。
我諗等 QE 嚟緊即係陣間會 share 我哋個 service model， 可能其實都 touch 到好多宗或者在座各位諗緊嗰啲嘢嘅，咁係啦，都可能解釋到部分你哋想知嘅，因為我哋都遇到你哋嘅問題啦，咁我哋都係當然大家都希望即係都可以解決到啊。
Before 去 QE 咧，我都好想用1分鐘，大家俾少少 comment 啦，就係嗱，其實除咗 hardware 之外咧，我都聽聞就係話其實個 software 咧都好緊要嘅。頭先我都聽阿 Alfred 講咗少少啦，其實會唔會嗰個 software 嗰個費用係可以貴到等於嗰個 hardware 嘅咧？阿 Alfred 有冇啲同我哋分享下？
其實都的確係㗎，即係譬如我哋講，即係用得最多嗰個啦，即係全世界 Mimix。咁其實一開頭咧，我哋即係10零20萬都有用，一加下咧都要搞到成70萬咁樣。咁
70萬係咪
？70萬係。咁佢有時咧又俾你逐年買，有時咧就可以永久啦。咁其實你70萬，你部機依家講緊我哋用開嗰部啊，都係130萬到嘅。咁70萬佢仲要係即係 maintenance 嗰方面可能包2-3年，咁即係佢又唔 update，咁所以其實就越嚟越貴嘅。咁變咗咧，佢雖然好乜嘢科都用得啦，但係又唔係真係非常之好用，所以我哋先至會話諗，不如我哋自己開發一啲咧，即係比較適合我哋用嘅軟件啦。另一方面又個成本方面又唔需要依賴即係去買呢啲 commercial 嘅 software 咯。
邱生講，可以。
我補充下啦，其實如果喺私人嗰度咧 ，Mimix 講緊係每一年要收我哋 license fee 成40到50萬嘅，所以其實即係我唔介意，譬如我一間俾咗可以俾咁多人用，都係一件再抵啲嘅事。真係好貴呢啲 software。OK。
但係我諗佢哋而家都發展都可能咧，即係可能都會就住啲user 會收費啦咁甚至乎我諗大家都知啦 ，Adobe 都佢其實而家越嚟越多咧，冇話呢啲咁昂貴特別嘅 software， 一啲普通嘅文件 software Adobe 嗰啲咁咧，佢都唔會有一個 perpetual license。我哋啲越嚟越用緊寫字樓用嘅電腦咧，佢都每一年要你 renew 你嗰個 license fee， 就冇一個永久嘅。咁所以我諗除咗 hardware 買部機之外咧，其實 software 個 development 都係會喺 3D printing 裏邊一個比較大嘅範疇，因為嗰部機都要靠Alfred去